Well, good morning, everyone, and welcome to day two of the State of Maine's Maternal and Child Health Substance Exposed Infant Virtual Conference for 2022. My name is Nirav Shah, and I'm the director of the State of Maine's Center for Disease Control and Prevention. And I'd like to welcome everyone back for day two of this year's virtual convening. I really hope that you all enjoyed day one and all of the discussions that it contained. I'd like to take a second this morning to recognize the event that we are all attending. As much as I wish we were all in person, and perhaps and hopefully next year we'll be able to be, the fact that so many people have taken time out of their schedules to come and attend and hear the latest is really meaningful. There have been over 600 registrants between the pre-conference and the conference events, and those 600 registrants span across 13 states. Now, events like this don't just come together on their own. They happen because of the hard and deliberate work of a lot of people. And I'd like to take a few moments to thank and recognize a few folks from across the attendee list who made this year's event happen. The first is someone you all know very well, which is Marianne Herrickle. Marianne's the program director for maternal and child health at Maine CDC. Working right alongside with her has been Dara Frichter, who's the program manager for our work around substance-exposed infants across the Maine CDC. Marianne and Dara have been assisted and joined by Danielle Dill, who you're going to hear from a little bit later. Danielle's the program director for our tobacco and substance use prevention work at Maine CDC. The internal team has gotten an assist from a lot of different folks as well. I want to take a second to thank our friends at AdCare for making everything happen. They've really been the backbone of a lot of our events, including this one, as well as the broader conference planning team, which is a team that's made up of state as well as community partners. Thank you all for your efforts in your planning, your time, and your dedication to this issue to bring all of us together. Events like this are meaningful, but I want to just acknowledge that they don't happen by accident. Day two of the conference promises to be as important and as meaningful as day one. We're going to be hearing about the growing network of resources that are available for children across the state. There will also be discussions on the effects of cannabis, as well as alcohol use during pregnancy, and how to manage the effects of syndromes like FASD. There will also be a workshop on how to navigate difficult conversations, especially those that surround trauma, substance use, pregnancy, and parenting. And as with yesterday, we will be weaving stories of recovery throughout the day so as to remind us why we do what we do and for whom we do it. Now, I'd like to take a second to pause and reflect on the size, the scope, the scale of the issues that we are discussing. Everyone here knows today that they demand our collective attention. Just in Maine, maternal, fetal, and infant mortality are significant public health issues. For example, with respect to infant mortality, in 2021 alone, there were 62 infant deaths. About a third of them were preterm related, and about a quarter were congenital anomalies. Turning to maternal mortality, between 2018 and 2020, there were 20 maternal deaths in Maine alone. 4 of those 20 were accidents or injuries, 3 were overdose related, and 2, very tragically, were suicide. The rest comprised other causes. Similarly, for fetal demise, in 2020 alone, there were 77 fetal deaths in Maine. Again, the size, the scope, and the scale of these problems demands our collective attention, which is precisely what we're doing today. But it takes more than a conference to turn and to move the needle on significant issues. There are key initiatives just in Maine that we have launched in recent weeks, months, and years to respond to these issues, specifically in just sticking with maternal, fetal, and infant mortality. We are making strides in improving our perinatal system of care through a robust working relationship with Maine's Perinatal Quality Collaborative, as well as working through the Locate tool, a US CDC tool, to determine the appropriate level of care for each and every birthing hospital in Maine. We're continuing an ongoing process of mortality reviews to learn more about systemic and social determinant causes that have led to things like maternal mortality. And we have big plans to improve both the birth as well as the death certificate collection process to improve the fidelity of the data that we use to make decisions around and understand the issues. I want to take a moment to thank and commend all of you for taking time out of your busy schedules to join us and discuss how we move forward with these issues in the state of Maine. In my previous post in another state, maternal mortality in particular, especially the racial disparity between white and Black maternal deaths, was one of our top priorities. And we showed that after several years of hard, deliberate work, we were able to make headway. I'm hoping we can do the same thing here in Maine. And the first and necessary step toward that work is doing what we're doing right now, coming together, sharing our ideas, discussing stories that affect the work we do, and charting a course forward. So thank you all for joining today. And thank you all for the work that you do. With that, I'm going to turn things over to our next team.
Good morning. My name is Angie Bellefleur, and I have the pleasure of introducing our next presentation. I am here to help facilitate a presentation on Maine's growing network of resources and tools for children every age and developmental stage. I have the honor of introducing our premier speaker, Dr. Paul Dworkin. And then after his presentation, we will transition to a panel of state experts on services here in Maine. So with that, I'm going to jump in and give you a little bit of Dr. Dworkin's background and turn it over to him. Dr. Paul Dworkin is the Executive Vice President for Community Child Health at Connecticut Children's Medical Center and Professor Emeritus of Pediatrics at the University of Connecticut School of Medicine. For 15 years, he previously served as Physician-in-Chief at Connecticut Children's and Chair of Pediatrics at UConn. Dr. Dworkin's interests are at the interface among child development, child health services, and child health policy. Dr. Dworkin's honors include teaching awards from both universities he has served, visiting professorships, and named lectureships. He was the editor of the Journal of Developmental and Behavioral Pediatrics from 1997 to 2002, and was a member of the first entering class of the Academy of Distinguished Educators at the University of Connecticut School of Medicine. In 2003, Dr. Dworkin received a prestigious C. Anderson Aldrich Award from the American Academy of Pediatrics in recognition of achievement in the field of child development. His vision led to the creation of Help Me Grow, a Connecticut statewide initiative to promote the early detection of children at risk for developmental and behavioral problems and their linkage to programs and services currently being replicated in more than 30 states. He currently serves as the project director for the North Hartford Ascend Pipeline, a U.S. Department of Education Promise Neighborhoods grantee. Dr. Dworkin received his bachelor's degree from Rutgers University and his medical degree from Johns Hopkins University School of Medicine. He completed his pediatric residency and fellowship training at Boston Children's Hospital. He earned a certificate in policy analysis from the University of North Dakota. Dr. Dworkin has served on the boards of numerous community organizations and completed his tenure as chair of the board of Urban League of Greater Hartford and currently serves on the board of the Institute for Child Success in Greenville, South Carolina. Without further ado, please join me in welcoming Dr. Dworkin and hearing more about his incredible work.
Thank you so much, Angie, and good morning, everyone. It's great to be with you. I share Dr. Shah's regret that we can't do it in person, but this is the next best thing, and we've become pretty adept at using technology to do this, so I just could not be more pleased to be with you. This is a remarkable conference. I've greatly appreciated the opportunity to view the agenda as a whole, and so appreciate the extent to which the organizers have maintained the appropriate focus on substance-exposed infants while placing this critical issue within the broader context of maternal, child, and family health and well-being to really address the drivers of the problem. So impressive and so worthwhile. Also, while I recognize that we have attendees from more than a dozen states, I do want to just give a shout out to Maine, and specifically our Help Me Grow Maine affiliate, with whom we've been working for a number of years and have so valued the opportunity to engage with this affiliate. And also, I would be remiss if I did not share our admiration and appreciation for the accelerated trajectory of their work and the extent to which they are really making remarkable progress. We know the challenges of exploring, installing, and implementing this model. It takes time, and Maine is on a trajectory that will absolutely ensure their success. So I'm so pleased to be with you, and I'm grateful for the opportunity. So let me see if I can just advance. Yes, so I have nothing to disclose. So I often describe my career over more decades than I'd care to admit, although Angie exposed me a bit for how long I've been at this, as the relentless pursuit of the answer to the following question. What if our goal for child health services is not merely, and I put merely in quotes because obviously treating and preventing childhood diseases and disorders are extremely important. But what if our goal is not merely that, but is also to promote children's optimal healthy development? And for many years, I thought this was a rhetorical question. I wasn't quite sure even if there was an answer. And then I gradually became convinced that not only was there an answer, but the answer is in the affirmative. That is, this is exactly what we must do. Place a greater emphasis on promoting children's optimal health, development, and well-being. And if you accept that premise, that then begs the following question. How do we best transform child health services, or I would even say child serving services in general, to strengthen families, to promote children's optimal health, development, and well-being? And this is the specific question that we have been addressing over the past 3+ decades, clearly since the 1990s. And it's important to put this work in that historical context, because the 1990s were referred to as the decade of the brain. And this is evident if you look at, for example, cover stories in the popular press. Here's a Time magazine article on how a child's brain develops. Or if you look at the professional press, including this really critically important publication of the National Academy of Medicine, From Neurons to Neighborhoods, the Science of Early Childhood Development. In the 1990s, the explosion in our knowledge of brain development, of early child development, that really was being amassed since the 1960s, 70s, and 80s, really came to the fore and began to inform and influence our thinking. So, for example, there are a whole host of critical concepts in brain development that yield critically important implications for the manner in which we go about strengthening families to promote children's optimal health, development, and well-being. I cite just a couple of examples. The fact that brain growth disproportionately occurs during the prenatal period and the earliest years of life. The fact that neuroplasticity, the ability of brain cells and portions of the brain to assume functionality when other cells or regions of the brain are injured, is a lifelong attribute. Think about, for example, the way in which we go about addressing stroke rehabilitation in adults. But neuroplasticity is particularly opportune during the earliest years of life. That there are critical periods of development in which stimulation and experience must be present in order for brain development and subsequently human development to proceed normally. Think about, for example, the devastating effects of deprivation during early childhood and the impact that that has on long-term brain development and child development. The fact that brain development is sequential, therefore experiences need to be sequential. Few infants will benefit from an algebra lesson. Few adolescents need to be held and rocked each day. Experience must be aligned with the stage of brain development. And finally, last but certainly not least, the critical importance of the role of experience in brain development. And this is a concept that we often use when we're speaking, for example, with policymakers who may not have had a heavy exposure to the science of brain development in their education, because it's so easy to illustrate that of which we are speaking here. So these are cross-sections of the brain with brain cells, neurons, and the connections among brain cells, which are referred to as synapses. And as you can see, from newborn to a month to 9 months to 2 years of age, there is remarkable increase in the density of neurons and synapses, but this only occurs if there is appropriate exposure to enriching experiences. Without that exposure, this does not occur. Similarly, you can see that from 2 years to an adult brain, there is a thinning, a pruning of these connections to eliminate those that are redundant and unnecessary, to preserve those that are critically important to achieve optimal brain functioning and efficiency, and to lead to healthy development. Again, this only occurs with exposure to enriching, stimulating experiences. Critically important. And obviously, the implications of this are pretty obvious when it comes to how we go about developmental promotion, the importance of early detection, and relatedly, the importance of early intervention. Just as there are critical concepts in brain development, there are similarly critical concepts in early child development. And I want to share with you one such critical concept because, again, of its enormously important implications. And this is the concept of developmental trajectories that has been advanced by our colleague, Dr. Neil Halfon, who directs the UCLA Center for Healthier Children, Families, and Communities. And what Halfon has pointed out is that if we think about children along different developmental trajectories. Of course, there are those children who are progressing along a delayed and or disordered trajectory, such as, unfortunately, so many children who are exposed to various substances during the prenatal period. These are the children who were my patients as a developmental and behavioral pediatrician. Depending upon the specific population of which we are speaking, this represents about 12 to 15% of children. Similarly, there are a large number of children who are fortunately progressing along a so-called healthy trajectory. These are children who are doing well and for whom developmental promotion remains important, but we do not need to think about interventions or special programs or services. While it's tempting to think about this as the vast majority of children, this actually represents, again, depending upon the specific population of which we are speaking, about 60% to 70% of children. For there is another very significant group that we have tended in the past to not pay sufficient attention. These are children who are vulnerable and at risk, who may, with the right supports, be elevated to a healthy trajectory, but all too often, due to adverse circumstances, adverse social, environmental, and behavioral factors, wind up deteriorating to a delayed and or disordered trajectory. And we've worked with the CDC to try to answer the question, what percentage of children are we speaking of? And again, it depends on the specific population, but in general, the CDC has encouraged us to view this population as having a prevalence of 25 to 30%. That's a very significant number of children. So this notion of at-risk trajectory is extremely important. Relatedly, this concept is also important because it acknowledges that there are factors that may adversely impact a child's developmental trajectory and cause an at-risk child to become a child along the delayed or disordered trajectory. And I give you just a couple of examples: socioeconomic disparities, lack of access to high quality health services, domestic violence, among many, many others, including substance exposure during the prenatal period. However, there are also a whole host of factors, positive attributes that can elevate a child's developmental trajectory from that of being at risk to that of being healthy. And you know what these are as well as I. Again, I offer just some examples: parent education, parent emotional well-being, health literacy, a protective home environment, access to a high-quality medical home, quality early care and education programs and services, and neighborhood safety and support. Such a critically important concept. And the implications of this concept were actually articulated many years ago, and I'll offer you a quote in just a moment. But what I would also point out to you is that if we think about the interventions that we have at our disposal, those interventions, programs, services, treatments are particularly impactful in advancing the developmental trajectory of children along an at-risk trajectory, as opposed to children who are already delayed and or disabled. Of course, we must provide optimal services to them. And this is also impacted by children's financial status. So this is a meta-analysis that was performed on interventions that advance children's developmental trajectories. And if you look at the interventions, which are the brown dots that you could see, you will see that the majority of interventions that are efficacious are those that address the needs of vulnerable children. You have to watch quickly, but the dots that move to your right are those that are impactful, and they are primarily those that address the needs of vulnerable children. In addition, I'm sure many of you are familiar with the work of Nobel laureate economist James Heckman and the so-called Heckman Equation. But what his work so clearly illustrates is that if we're talking about making sound investments that pay off, including with a return on investment, cost savings, cost benefit, the greatest opportunity is in early childhood. So if you take all of these concepts and consider them together, here is the implication. And Bob Chamberlain, a pediatrician who actually spent much of his career in New Hampshire, captured this implication way back in 1992. We are still working to catch up with the wisdom of what Chamberlain has recommended. The most effective long-term strategy appears to be the development of a comprehensive, coordinated, community-wide approach focused on preventing low and medium-risk families from becoming high risk, as well as, of course, providing intensive services to those who have already reached a high-risk status. So with the knowledge of brain development, with the knowledge of early child development, with the understanding of developmental trajectories that we had in the 1990s, we had the opportunity to undertake in Hartford a series of conversations asking the question, how can we best strengthen service delivery to strengthen families' capacity to promote their children's optimal health, development, and well-being. And with funding from our local foundation, the Hartford Foundation for Public Giving, we engaged in these critical community conversations with early care and education and health providers, with families and residents, with government officials, with community-based organizations, with trusted community leaders. And we were stunned by how quickly we came to 4 commonly held assumptions. That in Hartford, which, by the way, is a very poor city and is also the capital, as you likely know, of Connecticut, the state with the highest per capita income in the country. So the disparities within Hartford are striking and of critical importance. Here were our 4 assumptions. The children with developmental and behavioral problems were escaping early detection. This was obvious. One only needed to visit in an elementary school classroom. That 2, there were a wide array of initiatives in place that existed to provide services to young children and their families. But 3rd, there was a gap between the best efforts of child health and early care and education providers to identify vulnerable children and their linkage to these community-based programs and services. And finally, the children and their families would benefit from a coordinated region-wide system of early detection and intervention for children at developmental risk. So with those 4 assumptions in mind, we undertook a pilot study, the core components of which still constitute the Help Me Grow system model today. 4 core components: the training of child health providers in effective early detection, so-called developmental surveillance and screening, family and community outreach to encourage parents to recognize the importance of sharing their opinions, their priorities, and concerns for their children's health, development, and well-being, and community outreach to engage the community-based programs and services available to strengthen families and to inform both families and community-based programs as to the availability of this program to address the linkage issue. Third, the centralized access point and information and referral line staffed by care coordinators who can speak with families, elicit and clarify their concerns, and effectively link them to community-based programs and services. And then fourth, because we knew there were gaps, we knew there were capacity issues, and we also knew that we would need to be able to demonstrate the efficacy of the model if we hoped to bring it to scale and impact, not just across the city, but across the state. The fourth component is data collection and analysis. And again, these were the four core components in our pilot study in Hartford that remain the four core components of the Help Me Grow system model today. And many of you are in states in which the Help Me Grow system model is operating and are likely, hopefully, familiar with this. Again, each of the core components have specific key activities that we have identified, and we could speak to the extent to which the model is being implemented with fidelity to ensure successful outcomes. The story of Help Me Grow and the evolution of Help Me Grow has so exceeded our expectations. I will be the first to acknowledge that our hope was that we would develop a model that could be sustained in Hartford, and if we were fortunate, could be disseminated across the state of Connecticut. And in fact, that happened between 1997 and 2002. 2002 was the first year in which support for Help Me Grow was embedded within the state budget, and it has remained embedded in every biennial budget since. And today, as we speak, Help Me Grow is a program of the state's Office of Early Childhood. In 2005, we received a request from colleagues in Orange County, California, who said they needed Help Me Grow. Could we provide technical assistance? We said we were happy to try, and Help Me Grow Orange County today is a really remarkably vibrant, successful model of the system. We then were confident that we had the capacity to begin replication, and thanks to support from a number of foundations, replication began to spread, first to 5 states. We then developed the Help Me Grow National Center around 2010, and today, as we speak, we have 120 Help Me Grow systems across 29 states and the District of Columbia, and as you can see, we have a heavy presence in New England and the surrounding area, so many of you are in states with Help Me Grow systems. So how do we know what we're doing is making a difference? And how do we measure the efficacy of a wide array of programs and services that are designed to strengthen families, to promote children's optimal health, development, and well-being? Well, we know that the long-term outcomes that we are seeking are elusive over the short term, but critically important for us to measure. Academic outcomes, occupational outcomes, societal outcomes. And we are attempting to gather all of that data, but it will take years. We need a short-term indication as to whether the work that we are doing is impactful and will lead to the long-term outcomes. We need so-called proximate measures that we can measure, that we can impact, and that we know correlate with the long-term elusive outcomes that we are seeking. So we have collaborated with the Center for the Study of Social Policy in Washington, D.C., and their protective factors framework to use strengthening families and the 5 attributes of strengthening families to measure the impact of the work that we are doing within Help Me Grow and more broadly. So if we are strengthening parental resilience, family social connections, families' knowledge of parenting and child development, families' access to concrete support in times of need, and families' capacity to promote the social and emotional competence of children, we know that we are leading to the long-term outcomes that we are seeking. There have been 2 studies, one in Connecticut, one in Utah, conducted by independent investigators that speak to the extent to which families who are served by the Help Me Grow model have strengthened protective factors. So, what we didn't anticipate from the outset of our work is the extent to which the Help Me Grow model would yield implications for comprehensive system building. And yet, as I will demonstrate for you as I conclude my talk, that is absolutely the case today. And I wanted to share with you very briefly just a half a dozen of the many implications for system building that have evolved from our work. We know that we must advance a universal approach with, as Chamberlain stated, a particular focus on vulnerable children at risk for adverse developmental and behavioral outcomes to maximize value and impact. And we've employed an approach called targeted universalism, in which we provide and advocate for programs and services for the entire population, but ensure that those at the greatest risk have particularly expedited access. Number 2, as we've already suggested, go beyond the prevention of delays, disorders, and diseases to also promote children's optimal health, development, and well-being. That's a different set of strategies. Number 3, as we've stated, embrace the implications of the biology of adversity, adverse childhood experiences, toxic stress, social determinants of health, to enable families to promote children's optimal health, development, and well-being. Number 4, enhance family engagement and the impact of health services, as well as other child-serving services, by encouraging a family-led agenda. Families are the experts in their children's development. Families know their critical priorities, needs, and concerns. We must elicit and solicit them to drive our programs, our services, and our processes. And we are now embarking on an initiative called Goal Concordant Care that will hopefully embed this approach within our service delivery system. Number 5, recognize the imperative of embedding efficacious interventions within the context of a comprehensive early childhood system and building that system within our jargon, all sectors in cross-sector collaboration. You know this because if you look at the attendance for this conference, it is absolutely multidisciplinary, multi-sector representation. And then finally, as you all know, respond to the extraordinary contemporary imperatives to drive the creation of a nurturing environment for all children and families. I mentioned targeted universalism and its opportunity to move forward social and racial justice. You all know the impact of the pandemic on families' basic needs. These are some of the most cogent, most important implications for system building. So why am I optimistic that we are making progress and have the opportunity to move forward? But I'll look at the work that we are currently doing. So for those of you who are engaged with Help Me Grow model building, we have a new Help Me Grow strategic plan that we just launched in this year for the next 5 years with 5 growth priorities. And I am confident that we will achieve these growth priorities, bring the model to scale and impact to enable all families, all children to benefit. Secondly, I mentioned the work that we are doing in Goal Concordant Care, and we are launching a Goal Concordant Care initiative that will engage our affiliates and place families' priorities, needs, and concerns at the center of all that we do. We know that the work that we are doing has a return on investment. We have a return on investment calculator that shows the savings accrued from a comprehensive integrated approach to developmental promotion, early detection, referral, and linkage. And we are using this in states to encourage states to make investments in early childhood comprehensive system building. We know the importance of applying technology, and through Pediatric Supporting Parents, we've been involved in an initiative that is bringing a technology platform forward to engage parents in capturing their priorities, needs, and concerns, and driving the focus of our programs and services. And I would also stress that we are partnering with the Harvard Center on the Developing Child to make sure that we are taking advantage of the latest scientific advances, including the ability at a very, very young age to identify those children who are biologically predisposed to adverse outcomes from adverse social drivers, or who are biologically predisposed to be resilient, so we can tailor our interventions. So finally, let me just reference for you an initiative that we are just now launching. We've just been funded by the Health Resources and Services Administration to partner with 0 to 3 and the American Academy of Pediatrics in a very ambitious initiative called Early Childhood Developmental Health Systems Evidence to Impact, in which we are going to take those implications that I shared with you and bring them to scale and to impact in a number of states across the country. And simultaneously, we're working with the American Academy of Pediatrics to transform pediatric health services to ensure that it can optimally work to strengthen families, to promote children's optimal health, development, and well-being. So I hope that excites you about the Help Me Grow model. I hope that places Help Me Grow in the appropriate context for you, the need for comprehensive system building, and most importantly, the need for centering families and parents' priorities, concerns, and needs in all that we do. Thank you again for the opportunity to speak with you.
Dr. Dworkin, that was amazing. Thank you so very much for such an inspiring way to set the stage for our work here in Maine. I will say I was remiss in inviting our participants today to submit questions in the chat. So I just want to make sure folks know we do have a few more minutes of Dr. Dworkin's time. So if you have some particular questions for him, please feel free to drop them in the chat, and we'll see if we can get any of those answered today, this morning, while we've got his precious time. If not, we will do our best to find answers and get them to you as appropriate. So while we're waiting for folks to think about that questions that they might have, you know, Dr. Dworkin, when you were speaking, what really resonated for me was how today you linked the importance of that science and that brain development straight through into the services, and then the linkage between seeking out that community voice and then bringing that down even one more layer into that family lens. It was incredibly powerful, and very much what we're trying to do here in Maine is really put family and community voice at the forefront of and driver of the services that we're providing. So I just wanted to say that was particularly relevant for what's happening here in Maine. And I wonder if you had any additional thoughts that you might want to share with us related to really focusing on that family voice and that community driving what we know from science and data is really best practice.
Yeah, thanks, Angie. It's such a critically important point. And actually, I would say points, because both community and families are so critical to this work. And I'll give you two quick examples. I didn't have time to speak to work that we are doing with a U.S. Department of Education Promise Neighborhoods grant that we just received last October. And this work is related to that which I discussed regarding Help Me Grow. It's to build a cradle to career, really a prenatal to career pipeline for families residing in North Hartford's three poorest neighborhoods, three neighborhoods that have been designated as Promise Zone neighborhoods back in the Obama administration. So we received a grant for $30 million. And I say that not to boast in any way, but just to point out, the minute that word gets out that you've received $30 million and actually $34 million in matching dollars. So we had $64 million to do this work over 5 years. Immediately, questions arise as to how the dollars will be spent. So we had a community convening with the mayor and I speaking about the grant and how we propose to engage the community. And it was obvious that we were beginning from a zero trust standpoint. That is, and there was no reason for the community to trust us, particularly underserved communities who have not benefited in the past, when grants typically meant people would come in, do their research and leave without benefits. So the phrase that I've repeated continually, including last evening at our monthly community convening with more than 60 community residents in attendance, is the Stephen Covey, the author Stephen Covey quote, "These things move at the speed of trust." It is so critically important to be mindful of the importance of building trust with the community as a partner in this work. And I know you know that because I know enough about what's going on in Maine that you've embraced that, and it's critically important. Let me just speak for a moment about families and speak specifically about the early detection process, which is perhaps the easiest to speak of because everybody's familiar with developmental screening. And this notion that you administer a tool, you score it, and then that's an algorithm for whether you refer and not refer. And that is incorrect. I mean, we could spend an hour talking about that. Screening is critically important, don't get me wrong, but it must be implemented within a comprehensive, integrated approach to developmental promotion, early detection, referral, and linkage. And the early detection process must include both developmental monitoring and screening. Developmental monitoring is specifically on a continual basis, eliciting families' opinions, priorities, and concerns. So if you look at, for example, the policy of the American Academy of Pediatrics, it has moved from a focus on developmental screening to a focus in the early 2000s and most recently in 2020 to a focus on developmental surveillance and screening, where the surveillance piece includes eliciting families' opinions, priorities, and concerns. And now we are together moving to the latest iteration with the CDC, which you will all hear much more about, which is called Family Engaged Developmental Monitoring, in which eliciting families' priorities, opinions, and concerns is the single most important element of the early detection process, not in any way undermining the importance of also using screening tools. So these are not just trends. This is the way that we currently must go about business. And success will be predicated on successful community co-production, community leadership, community partnership, and family engagement, which has now evolved to family co-production and family partnership.
Absolutely, could not agree more. People are going to think we set the stage here a little bit because that leads directly into the next question that has come up on the chat. Some folks watching this morning are interested if you had any perspective related to the impact of the pandemic and the focus on families, and if you had any thoughts around what you might have seen across the nation.
Yes. Thank you. And I did make general reference to that, but thanks for the opportunity to expand just briefly on it. So we recognize, although it wasn't our initial intent, we recognize the powerful capacity of a model that engages families, identifies their priorities, needs, and concerns, and links families to community-based programs and services. And fortunately, our funders recognize this also. So at the peak of the pandemic, one of our foundation funders, a very large foundation, came to us and said, we want to support families and address family needs during the pandemic. Can you help us do this? And we said, we're pleased to try. So we, in partnership with our affiliates, we were very quickly able to survey families' priorities, needs, and concerns. And no one will be surprised that they basically were primarily, but not exclusively, in three major categories: basic needs, so diapers, wipes, food, formula. Secondly, access to childcare, early care, and education services. And third, access to supports for behavioral health needs. Those were the three big areas that quickly surfaced in this national survey. So we reported that back to the foundation, and they said, can you help us distribute the money that would enable local programs and services to meet those needs, using Help Me Grow and its central access point as the intermediary? And we said yes, and within a very short period of time, we had distributed over $1 million in support to address families' basic needs. So the model has tremendous applicability, but again, it's so important that these critical concepts be the attributes of the model. And we've learned a lot about what families' needs are. I think the greatest lesson was follow the lead of families. Families can tell you what their priorities, needs, and concerns are. And again, that should be the driver for all that we do.
Great, thank you so much. And if you'd honor us, just one more question.
Sure.
So one of the things that we often struggle with here in Maine is the diversity of our landscape, particularly a small population, but a lot of land.
Yes.
And so if you had any wisdom or thoughts that you might want to share with us related either to Help Me Grow or other services, in the impact that you've seen between rural and urban sort of communities and strategies that have worked in other ways.
Yeah, great, Angie. And obviously that also is uppermost in my mind, knowing what I know about Maine. And it's such a critical issue. So here I'll just briefly share. So I was engaged with the first two initiatives under the Home Visiting COIN, the Home Visiting Collaborative Improvement and Innovation Network. And our work there was to strengthen the capacity of home visitors to engage with families, identify needs, and ensure that families had access to the programs and services that they needed. And what came through, and I can't recall the exact number of states or home visiting programs that participated in each of the COINs, but it's a sizable number. And it was so clear that home visitors who were working in rural areas were particularly challenged to capture the resources and do the referral and linkage. Not so much in their immediate environment, but as the jurisdiction that they supported was more expansive. And this critical need to capture programs and services across broad expanses and to develop a portal of entry that enabled families to access them is in many respects even more challenging in the rural area than it is in the urban core. So I would make 2 points based on our experience. Number one, I referenced targeted universalism. And while I'll use the example of Help Me Grow as a universal program, any child, any family, a critical measure for us is the extent to which the centralized access point is being accessed by families in the urban core and in the rural periphery. And we always look to ensure that families within those areas are disproportionately using Help Me Grow because we know they need it the most. And that has been our experience in Connecticut when there are report outs on the so-called 5 Connecticut's. Those are the 2 regions that derive the greatest benefit. Secondly, in the home visiting experience, when home visitors have had access to a Help Me Grow model, a centralized access point in rural areas, it has greatly, greatly accelerated their capacity to do that successful referral and linkage. So it's particularly challenging, but also particularly important. And think about the problems and the challenges of family navigators needing to figure that out on their own when an integrated approach may capture the programs and services for them so they don't have to do that heavy lifting and can focus on engaging with families.
Thank you so much. Again, we learn so much every time we hear you speak. It's incredibly helpful to think about how we support both our Help Me Grow program and also our full service array, which we are about to transition into with our panel. So again, thank you for your time. You're more than welcome to stay with us, but I know that your time is precious, so we recognize if you need to pop off, whatever is most comfortable for you. So if with that, I am going to sort of wrap up our time with you and transition us to our state leadership panel. So what I'm going to share my screen for folks. I think this should be working. If someone wants to let me know if it's not. We have a full array of speakers with us this morning, and please feel free to drop questions in the chat if you have the time. If we don't have time, because we have such a robust panel this morning, we will definitely create an FAQ and make sure that it's up on our Help Me Grow website and make sure that any unanswered questions are addressed appropriately. So without further ado, I'm going to hand the floor over to Associate Director Alyssa Wynn, and she is going to provide a summary of OCFS programmatic services, including where Help Me Grow sits within the state of Maine.
Thank you, Angie. Thank you, Dr. Dworkin. And it was nice to hear from Dr. Shah as well this morning. I'm going to briefly just talk about the commitment to children across the State Department, as well as Angie said, talk about where Help Me Grow fits within the Office of Child and Family Services. To get us started, I just wanted to talk and remind folks about the commitment by our Governor, Janet Mills, to children, and in her inaugural address, she committed to bringing the Children's Cabinet back together again after it had not been together for a number of years. So I'm just going to read what she said in her address to remind folks. There's no higher priority than our children, and it's high time we put children's health and safety first. I will start with one simple step, calling together the Children's Cabinet for the first time in years to tackle these issues. So she did just that. The Governor's Children's Cabinet has been meeting, and it is a compilation of the commissioners across departments. So Department of Health and Human Services, as well as the Departments of Labor, Public Safety, Corrections, and Education. And so the Children's Cabinet has two strategic overarching goals. And one of them that I want to talk about today is that all Maine children enter kindergarten prepared to succeed. And so you'll see on the slide here, as part of the Children's Cabinet strategic plan, there's a focus on making sure that children have access to high quality services, including childcare and other early education programs. And one of the ways that we do that is through a focus on workforce. So on the Children's Cabinet website, you can see the strategic plan as well as the accomplishments that the Children's Cabinet has been able to move forward by working together. Next slide. Thank you. So now I'm going to talk a little bit about the Department of Health and Human Services and some of the opportunities that we have here. But before I get to the specific programs that we oversee and work within our office, I just wanted to remind folks where the Office of Child and Family Services sits within the larger DHHS landscape. And so this slide will help me do that. As you can see, Commissioner Jean Lambrou oversees a number of different offices within her purview of the Health and Human Services Commissioner. And you'll hear from a few of those offices today, including the CDC. However, I wanted to draw your specific attention to, on the left, second down, is Dr. Todd Landry. He's the director of the Office of Child and Family Services. And within the Office of Child and Family Services, we have three core programmatic functions. And so that is our child welfare services. You'll hear a little bit from them today as well. And then we also have children's behavioral health services and early care and education services. So those three core components. Next slide. Thank you. So I'm the associate director that oversees our early care and education service array, as well as children's behavioral health. There's a lot of initiatives that cross over between those two core programmatic areas that are intended to support children and families. We've, in the past 4 years, have made incredible strides in being able to roll out high quality programming that supports families directly. And so again, you're going to hear from some of these incredible program managers and their staff today. But I wanted to just share a little bit about within our early care and education team, we have these four core programmatic areas. So over on the left, we have childcare services. That's overseen by our childcare program manager, Crystal Arbor. She is the state liaison to the Administration for Children and Families regarding all things childcare. And so that funding source, which is the Child Care Development Fund block grant, gives monies to the states to oversee quality programming, professional development and technical assistance, licensing to ensure basic health and safety is met, and a slew of other programs that support childcare providers. Second, right now, today, actually, you'll hear from the Early Childhood Consultation Partnership Program Manager, that's Amy Bolyu. She has led the charge in implementing this program during a pandemic. It is the only evidence-based early childhood infant mental health consultation program in the nation, and we have implemented during a global pandemic. So I'm looking forward to you being able to hear from her about that program. Next, you have heard from Dr. Dworkin and our Help Me Grow program manager, Angie Bellefleur, this morning, and you will hear from Melinda, who's our Help Me Grow outreach specialist, about Help Me Grow in Maine and how we're implementing it. I do just want to call attention to the fact that our legislative partners have allocated funding and resources to the state in order for us to implement this program. And so another good example of the commitment of state across different departments and entities in order to support children in Maine. And then finally, a program that is about to get off the ground in January. It's a First for Me program, and it's a 2-generation approach to ensuring that children are ready for school and they're getting the comprehensive wraparound supports that they need in their early childhood settings in order to be ready for school. So that's just a very high-level overview of the programs that sit within our office, and I'll pause for any questions. Thank you. Back to you, Angie.
Thank you, Alyssa. A great stage setting for us as we transition into a deeper dive. So I appreciate your perspective. And at this point, we're going to transition to Melinda Corey. She is our Help Me Grow outreach specialist. She has been presenting on behalf of Help Me Grow to many of our key partners. And she is here to talk to you all to learn a little bit more about where we are and program planning and implementation. Melinda?
Good morning, everyone. I just want to first say thank you for the opportunity. Some of you may have already heard me present at this point as it's been a busy summer, but I'm excited for the opportunity to be here and to share a little bit more about what Help Me Grow is looking like here in the state of Maine. I thank Dr. Dworkin so much for being here and for the excellent description of the Help Me Grow model. I certainly could not do any better than that, but I am happy to be here to share a little bit more about how things are looking here for our implementation of this. So Help Me Grow here in Maine, a solution to help young children shine, is a way that we are connecting families with information and services. We have a partnership with 211 Maine, and by either contacting 211 or contacting Help Me Grow directly, caregivers as well as providers such as child health providers or early care and education providers can reach out for support. Our resource specialists will listen, share developmental information and community resources, refer children for services if necessary and appropriate, and then very importantly, provide follow-up to close the loop with various referral sources and caregivers. So we are an affiliate of the National Help Me Grow Network, which is so exciting. It's great to see how fast that is growing, and we're happy to be part of it. Our central access point is just about to get up and running. So we've been in a soft launch since May of this year, and we've served a handful of families already who have found their way to us through various avenues. And we anticipate to be fully live with our phone number and all of that sometime in the next month. We have a team that is fully staffed. So we have 3 resource specialists. We have myself as an outreach specialist, Angie as our program manager, and as well as an administrative assistant supporting the program. So we're very excited to have our team fully staffed and trained and ready to go. One of the things I want to highlight as well is Dr. Dworkin talked quite a bit about the importance of early monitoring and screening to ensure that we are catching any potential concerns when children are young. We all know the value of early intervention. And so a part of Help Me Grow here in Maine is supporting ages and stages developmental screening. And so all of our team members are trained in the ages and stages questionnaires and are able to actually train others. So if childcare providers or healthcare providers are looking to implement ages and stages in their programs or offices, we're able to support that getting going. And we are also supporting a pilot of ages and stages screening to be happening in 5 early care and education programs across the state. And we already have several dozen screening results in at this point. So we're very excited to be building the capacity of Maine's early care and education providers and helping them to have what they need to serve the children and families that they are working with, because we know what difficult and important work that really is. So the goals of Help Me Grow, Dr. Dworkin really reviewed the important components and how it all works, but the goals we've really been working hard towards here in Maine are primarily first to meet our mandate from the legislature, which funded us. And so that is to help families effectively utilize all the programs and services that are already out there in the state of Maine. And so we like to say there are lots of services out there and they're almost like little islands in a stream. We often hear from folks, the services seem so siloed, and we see that too. And so we want to be the boat that helps carry, the families around and get them really connected to all those islands of services so they're not so isolated anymore. We want to make sure in the end that we are increasing access to screening, diagnosis, and treatment services, as well as access to early intervention. So we plan to be a strong collaborative partner to child development services, both Part C, early intervention, and Part B, preschool special education. We are a great way for families to get connected with that system, and also a great way to provide additional supports for children who may need something outside of educational supports. And so we're excited about working together with CDS to increase what families are able to access. And I'll be meeting with all the various CDS teams this fall to start building that relationship even more. Another great aspect of what we can do through Help Me Grow here in Maine is that although we cannot fill every gap, we know there are gaps in services. We hear this anecdotally from providers, from parents, and it's frustrating for everybody. And so an important part of what Help Me Grow does is keep data on what the unmet needs and unmet services are around the state. And so that information can be gathered and used to advocate for what needs funding in our state. What's the next step? Where do we need to move forward to better serve families? And so in everything, our goal is to collaborate with our community partners in early childhood and in child health as we move our program forward to our full launch. We have been doing outreach all summer, and we have reached over 250 child health providers and over 60 community providers, with lots more on the books. So if you haven't seen my face yet, you probably will sometime in the next 6 months. And we're also tabling at a number of upcoming conferences this fall and into the spring. So I hope to be meeting more people face to face and getting to share more about the program. My contact information, as well as the program's contact information, is here. Our website is live and ready to go if you want to check that out. And I look forward to helping this program grow for the children of Maine. Thank you.
Thank you, Melinda. You always do such a great job at describing what we're doing and where we're going. I'm so proud to be a partner and working with you. So thank you again. And again, folks that are, if there are particular questions, drop them in the chat and we will certainly make sure to get appropriate answers back to you as needed. Thanks, Melinda. And we're going to transition now to our next team partner. Amy Bolyu is the program manager for the Maine Early Childhood Consultation Partnership. We often refer to each other as sister programs and try to collaborate and partner and team as much as we can. So I'm proud to be working here with Amy as well. And I'm happy to turn the floor over to you for you to share a little bit more about your program.
Great, thanks, Angie. Can everybody hear me? Angie, give me a thumbs up if I'm coming through. Okay, thank you. I always like to check. So as Angie said, I am Amy Bolyu. I'm a licensed clinical social worker, and I am the program manager for the ECCP program, which is OCFS's new-ish program for infant and early childhood mental health consultation. So next slide, if you can, Angie. Thanks. So what is ECCP? ECCP is an evidence-based infant and early childhood mental health consultation model, as Alyssa stated before in her remarks. ECCP is a model actually out of Connecticut. It's been affiliated with Help Me Grow and Dr. Dworkin's work there for quite a while. And it's been successfully implemented statewide in Connecticut for the last 20 years. It's the only research-supported model for infant and early childhood mental health consultation in the country. And so Maine elected to replicate this model here. We started in January of 2021 with 5 pilot sites. We were directed by legislative support in the 2019 session to create this model and pilot it. And then in the spring of last year, we expanded to 8 pilot sites. And I'll show you where those are. Exciting news is that we will be expanding ECCP statewide early in 2023. And so we're working very diligently on preparing for that. So getting into the specifics of what ECCP actually is and what mental health consultation can do. So we know that during the pandemic, social, emotional, and mental health concerns for young children and families grew even more. They were concerned before the pandemic. They certainly became even more pronounced during the pandemic. So our implementation of ECCP has been timely. This consultation is focused on prevention and early identification of young children and their mental health concerns. Even though our consultants are licensed mental health clinicians, we don't go in there and do active treatment or diagnosis. We're there to do active prevention and early intervention. And we do that in a couple of different ways. We have 3 core services that I'll explain in a minute that we can offer. And our services really focus on early childhood educators in various settings and helping them build their capacity to work with challenging behaviors and social emotional needs of young children. And we can also serve individual children who may be having some early signs of social, emotional, or behavioral challenges. The overall goal of ECCP and early childhood mental health consultation in Maine is to reduce the rate of suspension and expulsion of young children from their early care and education settings. We know that quality childcare is extremely hard to find. And once you find a slot, it's precious. And so we want to have children and their families be able to have sustainable connections to quality early care and education. And one way that we can support that is through ECCP. Our other goal is to improve the social emotional climate in early care and education settings as a whole. So thank you, Angie. Getting to our core services, we have 3 main types. Core classroom, which really focuses on the social emotional climate of a classroom as a whole. Our consultant will go in to a childcare center and work with a particular classroom and teachers in that classroom who may be struggling with a variety of issues. They may say, I'm really having trouble managing transitions with this particular group. You know, I have we hear this quite a bit. I have a group of very active kids and have tried all my bag of tricks and can't seem to manage the flow of the classroom, and I'm having a lot of disruptions. Can you help me? So our consultants can go in and do some focused work with teachers and providers on that. And we can work with any licensed childcare center or public pre-K program with core classroom services. We also offer a offshoot of that service specialized for family childcare providers. So those are home-based daycares. So consultants can go in and work with family childcare providers on improving the social emotional climate and functioning of their program as well. And then we also offer child-specific services. Those as consultation open to any child birth through age 8 who is enrolled in an early care and education setting that includes a licensed childcare center, a home-based daycare or family childcare, public pre-K, public elementary school up through age 8, and after school programs. Because we're a prevention program, we can get referrals for a variety of issues. A child really could be struggling with minor, what we might call minor or beginning social emotional issues such as withdrawal or just the early signs of anxiety. up through some very disruptive and challenging behaviors that may be threatening their ability to remain in the program. And so our consultants go in and do some very focused consultation with the staff, and the family is a vital part of this as well. That service is completely voluntary, and the family has to agree to participate, and they are an active participant in that. And we actually do home observations and meetings with the family as well as part of that. And so those are our main types of services. So next slide, please. Here is where we are currently offering services. Aroostook, Androscoggin, Cumberland, Hancock, Kennebec, Penobscot, Washington, and York counties. And as I mentioned previously, we'll be expanding statewide early in 2023. We have a total of 8 consultants funded at present. After we expand, we hope to expand to 16 total consultants statewide. And every county in Maine will have a full-time ECCP consultant available to them. So next slide. So how do you make a referral? Any referrals can go through, we try to keep it as low barrier as possible. Referrals can go through the local ECCP consultants. You can find who they are and their contact information on our website, and the link is right there. Or you could also connect with me, and I can connect you to the appropriate resource. And that can be a referral for an individual child, or if you're an early childhood educator and you're thinking or a home childcare provider and you would like our services for your program or your classroom as a whole, you can certainly either contact the consultant directly in your county or contact me and I will connect you. Okay, I think that's all that I have. Thank you so much. And I'll take any questions in the chat. And thank you so much for the opportunity.
Thank you, Amy. Every time I hear you speak, I learn a little bit more. It's like this service array that is so wonderful and so supportive of both children and the provider that wraps around those children, and such a valuable resource. I can't wait until we're statewide. Thank you so much. And I'm going to transition us to our next partner. Christine Theriault is joining us this morning. She is within the Office of Child and Family Services. She is going to be talking about an initiative that she has been leading around assisting both our providers and our families to identify services in a little bit more convenient manner. So a perfect partnership for Help Me Grow. So take it away, Christine.
Thank you, Angie, and good morning, everyone. So as Angie said, I'm Christine Theriault. I'm the Family First Prevention Services Program Manager within the Office of Child and Family Services. So I'm happy to be here to talk today with you all about Family First, as well as Access Maine, which is a new resource that we created to help locate services and supports for families in Maine. So the foundation of how Access Maine came to be is through a federal initiative called Family First Prevention Services Act. So this federal law was passed back in 2018. And it provides opportunities for Maine to receive some federal funding for evidence-based services that are really designed to prevent the need for removal from the home. So in addition to Family First, it also, in addition to prevention, it also sets some new standards for youth needing children's residential care facility services. So the overarching vision for Family First is really about keeping our children safe, strengthening families, and also reducing the need for foster care when it's safe to do so. So with this new initiative, we kind of established some prevention-related goals of bringing new or expanded services to Maine to really strengthen families again to prevent the need for foster care. We're currently in the process of rolling out the Home Builders Family Preservation and Reunification Program, and also working on expanding the Parents as Teachers program to expand eligibility up to the age of 5. So in line with what we've heard from stakeholders and staff, we created another goal to really look at increasing awareness of the existing resources that are in Maine to support families. So As a result of that, we've been doing biannual trainings for our staff with service providers in the community that have been coming and presenting information to our staff on the services that are available within each of the different regions. Several, probably the individuals in this conference have probably done those presentations, and we're going to be doing another round of those coming up in November and December. We've also created the State Agency Partnership for Prevention, which includes the gathering of multiple state agencies that are all funding or working towards prevention efforts across the state. Several of them are members of the Children's Cabinet, and so we're really excited to have that partnership to work together again for that continuing prevention. So lastly, we created this Family Services Resource Guide, also known as Access Maine. This is a guide that is really meant to complement our 211 system in the state. So Access Maine is the website for Access Maine is accessmaine.org. We tried to keep it really simple. So that is sort of the site of our newly developed Family Services Resource Guide. This is there's lots of animation. I apologize. So the audience for our guide is parents, caregivers, family members, providers, our OCFS staff. Basically, our audience is everyone who may be looking for services and supports across the state for families. So the content of the guide, again, as I said earlier, it's really meant to complement our 211 system in Maine. 211 has a lot of information about community level programs and services that can support families, and Access Maine is more focused on state level programs and public programs that can support and serve families. And so there's what you'll find when you visit Access Maine is an explanation of the site, as well as multiple tabs across the top with different categories of services, as well as some quick reference links near the bottom left of the page. So we provide a brief description of each of the programs and a link to a website. So again, we're trying to keep it really easy and simple to navigate. But all of the information will and the links will lead you to a website that has more information about how to access services and all of that. So we also include information on each page that includes how to access 211 Maine. Again, because the two systems complement each other, we want people to be able to know how to access information for community level providers. So we also have a Contact Us page, which is a way for people to provide feedback on the guide. It's not going to connect people directly to services, but it's going to give us an opportunity to hear how is it working, not working, and all of that. And so, in very, in a nutshell, we really think that this is an opportunity to expand how people know about services. And that's something that we heard greatly in our preparations for Family First, is that people needed to know what's out there to support families across the state. So here's my contact information, and certainly if you are a state level program or a public program that you feel you'd like to have in Access Maine, or if you have questions about Access Maine or even Family First, definitely contact me. I've included links to both 211 as well as Access Maine and our prevention services website, which will provide a lot more information about Family First and our implementation of that. We did create a fact sheet as well that includes information about how to access Maine, as well as what is the difference between Access Maine and 211. And our fact sheet is locating services and supports for families in Maine, because it really outlines those two resources for people. So included in these slides is a link to that fact sheet. We also did a webinar with 211 when we launched Access Maine in April of this year. And so we have a link to that webinar recording as well, which really kind of walks you through Access Maine, as well as walk you through sort of how to access information through 211 Maine as well. Again, happy to take any questions that anyone might have, and feel free to contact me. And again, thank you for the opportunity to talk about treating first and accessing.
Thank you, Christine. You've worked so hard on these resources. It's nice to see them live and being actively used. So thank you again. Thank you for your time sharing that with us. And there are a few questions that are coming through in the chat. If we get through, we have two more panel presentations. If we get through, maybe I'll invite everyone to come back on screen and we'll see if we have any ways to address those. So stay tuned for more. With that being said, I'd like to transition us to invite Nicole Dotson to share with us about activities that are happening in related to Maine's plan of safe care. I know that Nicole has been on board and working really hard and has a lot of great, exciting information to share about her work.
Thank you, and good morning. So today I'll be providing a brief overview of Maine's plan of safe care. To start with, I would like to give a brief historical background of the plan of safe care. If we can go to the next slide. So in 2016, the Comprehensive Addiction and Recovery Act, often referred to as CARA, which is a provision to the Child Abuse and Prevention Treatment Act, put focus on substance-exposed infants. CARA was the result of states appealing to the federal government for funding to help address the rising concerns of substance use disorder and substance-exposed infants. CARA made funds available for states to address these concerns, at the same time mandating that all substance-exposed infant births be reported to the state and that a plan of safe care be developed with these families. Next slide. The main statutes that address the development of a plan of safe care and mandated reporting are MRS 4004B and 4011B. The first one, 4004B, speaks to the responsibility of the state of Maine to respond to the report of an infant born substance exposed. The state will receive the notification, investigate, determine the effect of the substance on an infant, determine presence of abuse or neglect, and develop or contribute to a plan of safe care. 4011B addresses the report of a substance-exposed infant birth by medical provider, stating that a report of substance-exposed infant birth be made if there is a known or suspected prenatal substance exposure to legal or illegal drugs or fetal alcohol spectrum disorder, or if there is withdrawal symptoms that require monitoring or care beyond that of a standard newborn. Next slide, please. So the plan of safe care is intended to be a family-centered plan created jointly between a provider and the family. It is a family support tool, assists families in accessing resource needs, facilitates a conversation between family and caregiver, promotes safety and well-being for infant and families. Lastly, the plan of safe care can benefit all care providers working with the family. The benefit being that a provider can review a plan of safe care and see what resources the family is utilizing or has been offered and which resources a family has engaged with. Next slide, please. The ideal path of the plan of safe care would begin with the plan of safe care being developed prenatally, with referrals to identified resources needs being made at that time. As the family engages with these resources, the plan of safe care would be updated to reflect this interaction. Then at the time of birth, the plan of safe care could then be updated, or in some cases it would be developed at that time, if it hadn't been prenatally, and notification of a substance-exposed infant birth would happen at this time. Following the birth of the infant, the plan of safe care would continue to be updated. A copy would then be shared with the pediatric provider and shared with resource care providers. With that being said, a plan of safe care can be developed at any time for any family from the prenatal period up to the infant's first birthday. And a plan of safe care is meant to be utilized throughout the prenatal period and up to the infant's first birthday. And then last slide. This is my contact information. If you have any questions, concerns, please feel free to reach out to me. Thank you very much.
Thank you, Nicole. Very helpful, very organized. You got us right through it. I appreciate that so much. So let's transition to our last team member that's presenting today. We have Stacy Laflem. She is here as the program manager on the maternal and child health team. We work quite closely between our offices of Ocfs and Maine CDC. And she's going to share with us a little bit of information related to a project that's happening out of that office, the Pediatric and Behavioral Health Partnership. Stacy?
Good morning, and thank you, Angie. Good morning, everybody. My name is Stacy Laflem, and I am a maternal and child health program manager at the Maine CDC. Over the last 2 years, I have been working on an initiative, which is the Child and Adolescent Psychiatry Access Program. We are funded through HRSA. And we determined as a team that we were going to rename ourselves as the Maine Pediatric and Behavioral Health Partnership Program. And so our program is a partnership between the Maine CDC, Northern Light Acadia Hospital, and Maine Health. Next slide, Angie. So as many of us know, we are currently in a shortage with mental health professionals nationwide, and especially with child psychiatry. We also know that about 75% of patients who are experiencing mild to moderate behavioral health concerns first present in the primary care setting. So they initially go to their doctor to start sharing some concerns that either the patient, their child, or their family is seeing or school is seeing. And the program that we have established is considered a curbside consultation program. And so we really work hard at connecting primary care providers or anybody in the primary care setting, whether that's pediatricians, family practices, NPs, PAs, practice managers, with a psychiatrist or a behavioral health specialist through consultation. Next slide. So we have used the national model. It was originally created out of Massachusetts. And if anybody out of Massachusetts is familiar, it's called MCPAP. And so we are part of the National Association for Child Psychiatry and Access Programs. And that is the model we look to follow here in the state of Maine. We have only started implementation in March of 2021. But the mission is to educate, support, and empower primary care providers and their clinical teams through patient care consultations and ongoing training. When a primary care provider or clinician calls for a consultation, we work to match them with a child or adolescent psychiatrist or a behavioral health professional that can best meet their questions or their need. And again, we partner with Northern Light Acadia currently and Maine Health as our consultation providers. Next slide. We do have a consultation access line. So any provider that's in the primary care setting who has a question, and it could be child specific or it could be just general around behavioral health, mental health needs, can call the 1-800 number. We also have the website, the bhpartnersforme.org, and on our homepage, there is a request a consult link that a provider can click at any time, fill out that form, and that information comes to me or Kim Goslin, which is our program manager, and we then get it to our team to respond. So we have one part of the project, which is the consultations, but the other part of our project is professional development and education trainings. We do hold monthly webinars. We do offer CMEs. Our monthly webinars are on general mental health topics or components that we feel anybody in community or community services would benefit from anybody is open to attend. They are on the second Wednesday of the month from 7:30 to 8:30 a.m. We do record those webinars and we host them on our website for on-demand webinars. So you can go back and watch those recordings, and there's CMEs associated with that as well. And then recently we have started an echo learning series for primary care physicians and their clinical team members that meets on the first Wednesday of the month. And anybody that is in the primary care physician role is welcome to attend. And that's very beneficial because we do a 10-minute didactic, and then we have one of the physicians come with a case that they may be struggling with of how they're managing or maintaining children in the medical home model. And we have a panel of experts that can give them feedback and suggestions, and it just builds a really good collaborative care model and good support. So obviously, there's no financial disclosures. Not sure why that was at the end and not the beginning, but there it is. So anybody is more than welcome to contact us through the website or call the access line if anybody has any further questions. We, like I said, have been implemented since March of 2021. And since that time, we have been able to offer more than 560 consultations and help more than 560 children. And we are looking to expand that statewide. So thank you for your time and including me today.
Thank you, Stacy. Great job. I just want to say that I know many of us have gone into your on-demand webinars, and they have been remarkable and really reached a broad spectrum of our service providers here in Maine. So thank you for your great work. We appreciate it. We appreciate being partners with you. So I'm going to stop sharing our screen. We are right about at time. I'm somewhat impressed that we were able to get through that many presenters in the time that we had allotted to us. Thank you everyone who took your time to be here with us today. Thank you to our expert panel members. And again, thank you, Dr. Dworkin, for your time and effort in supporting the initiatives here in Maine. So thank you.
Good morning. I have the privilege of introducing Dr. Cheryl Ryan, MD. She will be discussing cannabis use during pregnancy. And after yesterday's conversation, I believe this is a topic many of you are interested in. Dr. Ryan is the Chief Division of Adolescent Medicine at Penn State Health, Milton S. Hershey Medical Center, and a pediatric medicine specialist. She is an expert on neonatal abstinence syndrome and the implications of cannabis use during pregnancy for neonatal and childhood outcomes. If time allows, we will take questions at the end, and I will monitor the chat. Welcome, Dr. Ryan.
Well, thank you so much. Thank you, Rob, for that introduction. And I'm going to share my screen now. Bring up my... Okay, and hopefully it'll be just the way we want to see it. Good. Okay, now I need to go back to the beginning. Oh no. Okay, here we go. Sorry, should have started. Okay, well, good morning, everyone. Well, I'm glad to have the opportunity to speak to you all today. And I'm going to be talking about marijuana use in both pregnancy and in breastfeeding. And my objectives today, first of all, I have nothing to disclose. And my objectives today, I'm going to start by describing the biology of marijuana, give you an idea about marijuana itself, cannabis products, and the endocannabinoid system that we all have in our systems as human beings. Then I'm going to talk about the adverse short-term and long-term health effects of marijuana exposure during pregnancy, and what we know about breastfeeding on both neonatal and fetal and neonatal development. And then finally, I'll discuss the recommendations for counseling women who are pregnant, planning pregnancy, or breastfeeding. Okay, so marijuana has been around a long time. It's not something that we invented in the 1960s. And you can see here that in 2900 BC, it was used in Chinese popular medicine. The Hebrews used it with anointing oils. The Egyptians used it 1200 BC for both glaucoma and inflammation. So they were using it for medicinal properties. And then in the, after BC, it was being used in the Arabic world. In the Middle Ages, it was central to herbalists' cabinet. And then it was brought to America in 1611 by our initial Jamestown settlers. And there's evidence that George Washington even cultivated hemp and smoked it. It wasn't until the 1800s in the United States that it became more of a mainstream of Western medicine. Many uses. People used it for headaches, for pain, appetite stimulant. And we have histories, people used it for a lot of these different reasons. And it was on the US pharmacopoeia as a patent medicine. So people made tinctures of it, and it was used for many of these disorders, including back then, it was used as a treatment for opiate addiction. And I like to show this. Slide. This was given to me by actually one of the American Academy Pediatrics presidents. And he found this up in his attic when he was cleaning out an attic from an old relative. And you can see over on the left-hand side, these are cigarettes, cannabis indica, which is one of the type of cannabis. And it says they were for the treatment of asthma, bronchitis, and maladies of the lungs. So you can see back in the 1800s, people were thinking that this was something that was useful for a variety of different things. Now, it wasn't until the 1900s that we started to have more restrictions on marijuana. So the 1906, we had our Pure Food and Drug Act, which was to try to standardize and label things better. Then we had the Harrison Act that was aimed at opium, later served as a basis for strict regulation of marijuana. Then you have in the 1920s, across the nations, multilateral League of Nations that were restricting cannabis use. And then we had in the 1930s, big efforts to control drug use that included marijuana. And there was, I don't know if any of you remember the Reefer Madness movie, that it showed that it caused insanity, and it pushed people to horrible criminal acts. But following that, then we really had a lot more restrictions. It became Schedule I, which it currently is. So it's currently still under those 1930s restrictions, federally illegal for marijuana, despite what our states have legalized and legislated. But the history of marijuana really is it's the second half of the 20th century. We first identified THC, which is the psychoactive component of cannabis that was first identified in the 60s. Then in 1990, we identified the endocannabinoid receptors, and endocannabinoids were first discovered in the early 1990s. And then we had, in 1996, California was the first state to legalize medical marijuana. Then in 2013, Colorado was the first state to legalize recreational marijuana. And now there are 38 states that have either legalized medical or recreational marijuana, and 19 of those states in DC have legalized marijuana. And if you just look at this map here, you can see the states, mostly in the Northeast and the West, are the ones that have legalized. And it's sort of a cluster of southern states, including Texas and some in the Midwest, that have no legal form of marijuana, whether it's for medicinal purposes or recreational purposes. Okay, so let's talk a little bit about the biology of cannabis. All right, so marijuana, when we talk about, I'm going to use marijuana and cannabis interchangeably. We talk about the cannabis plant, but when we talk about products, people talk about, cannabis products, or they just talk about marijuana in general. Okay, but the cannabis plant contains more than 200 biologically active substances, the cannabinoids. Okay, and there are numerous species and subspecies. There's cannabis sativa, cannabis indica are the two most common. and they cause a variety of psychotropic effects. But these species have been hybridized repeatedly. So there's it's kind of hard now to find one that's purely one versus the other. And there's more of a hybridization of the two. And that's pretty much what you're going to get if you're going into dispensary. You're going to get either some kind of hybridization between these two major species. Okay. So if we think about what it is that's the psychoactive component, that's delta-9 tetrahydrocannabinol, that's THC. That's the primary psychoactive cannabinoid in the marijuana plant. And that has high affinity for the CB receptors in the brain, which I'll be talking more about what these CB receptors, the cannabinoid receptors, are in the brain. But selective breeding, as I mentioned, has resulted not just in an interbreeding of these two main types of cannabis, but there have been concerted efforts to increase the amount of THC that's found in the plant products. So for example, from 1995 to 2013, okay, you started about 4% of THC was in your cannabis. And by about 2013, your average amount of THC in what you could get in the cannabis leaves and the cannabis plants was about 17%. Now it's really hard to find something that's under 15 to 20%. And there are some plants that have more than 20% of THC. And we also developed, we're very creative people. We develop new ways of producing things. So there are some new ways of creating even higher concentrations of THC, anywhere between 30 to 80% pure THC. And those are called, we use them dabbing, they're in volatilizing oils. I'll show you a picture of those in a minute. But these aren't just psychotropic, but people are worried now that they're much, much more psychotropic effects, as well as, along with the psychotropic effects, we're worried now that we're going to have increased risk of some of the adverse effects. So this gives you some idea of the kinds of things that you're going to see with these 40 to 80 to 90% pure THC concentrates. You can see the wax. There was one called earwax. There's butane hash oil, butter, and shatter. And all of these, what they do with them is you can put these in a little sort of a spoon or something. They're heated up. The oil volatilizes, and that's inhaled. And in some of these cases, you're getting 80 to 90% pure volatilized THC through these products. Okay. Now, this is in distinction to cannabidiol. So this is CBD. Cannabidiol is what you can go to the Cumberland Farms, you can go to the grocery stores, you can go to your gas stations, and you will see CBD cannabidiol oil. And this is the non-psychoactive cannabinoid. This mainly comes from hemp. It's not, that's the main source, which is a different type of cannabis plant. But this is not psychoactive. So it's a non-psychoactive cannabinoid, not like your THC. This has very low affinity for the cannabinoid receptors in the brain, slightly different mechanism that we'll be talking about more. It's an antagonist to those receptors. And in some cases, it potentiates the role of the CB receptors. And it can interfere with our innate endocannabinoid degradation. It also has other effects. It can be an agonist of some of our serotonin receptors in the brain. And people feel that that is one of the reasons that it is neuroprotective. It's also potent antioxidant and anti-inflammatory. So there are many, there's a focus on this for many different types of medicinal effects. And I think this is a really big area of research right now, with people trying to understand what is this product, how does it work, and what is it really effective for. But we still know very little about this product, about this substance. We know little about its dose response, and we really don't know how it acts, what's the mechanism of action for things like seizures, for example. We really don't understand why it works. So I think this is the kind of thing we need to stay tuned for, because I think our researchers are really, this is an area of active research. People are very interested in what's really going on. And I think we're going to be finding a lot more research as time goes on. All right, so this is just to show you with this selective breeding, what's really happened. This is from 1995 to 2019. You can see that the increase, the red line is your the THC concentration in cannabis samples. These would just happen to be seized by the DEA. And you can see that back in 95, it was hard to find something that was more than 4%. Now we're looking at 14%. And I know you can go into some of these recreational dispensaries and get things that are more than 20% pure, more 20% THC. But at the same time, what we're also been seeing is that as the THC in the cannabis samples is increased, they're also not even selective. As a result, the percentage of CBD that just happens to go along for the ride in the marijuana plant is just we're getting smaller and smaller percentages. And it's not clear whether some of the effect of medicinal marijuana plant separate from the CBD, it could be that we're going to be seeing fewer and fewer of those effects because we're selectively pulling out the CBD from the marijuana plant. And that may mean some of the medicinal effects of the pure plant are going to be diminished. I think that's what some people are concerned about, because we're getting much lower levels of the CBD versus the THC. Okay, so I do want to mention that because, again, federally, it is illegal. Marijuana is considered Schedule I substance. It's determined to have what Schedule I means, it has no medical benefit, despite what we're finding. So the problem is it's outside the purview of our FDA. There's no standardization. There's no way that we know how to, when you get something, has it been regulated by the FDA? Does it have a certain amount of dosage that you know you're going to get? There's really no standardization. So there have been a couple of studies I wanted to just cite here. There was a study done from the Netherlands, which has had marijuana legal for quite some time. And they just reviewed they collected 46 cannabis samples provided by consumers, and they went to dispensaries, and they wanted to see, they don't have any standardization in Netherlands any more than we do in the United States. So they wanted to see whether what you buy and what is advertised is what you get. So they analyzed these 46 samples for THC and CBD, and they found that there's virtually very little connection between what you say you're going to get versus what you get. So they found that what differed, the label claimed to give you differed very much from what was actually in the content. So they found that several had a much lower amount of CBD or cannabidiol than advertised. Some had way more. One in particular had like 56%, 57% of THC when it's sort of advertised, 10%. So you can see that many of these products, because they're not standardized through the FDA, are mislabeled by what is actually present in the product. And there was another study that also said, are there things in there beyond THC and CBD that you don't want to have in there? So this was another study done that looked at contaminants in both home and commercially prepared samples of these medicinal products. So they just grabbed a whole bunch of different ones and said, what's in these things? And they found that there are a significant number still contained things advertised as eliminated. So solvents, the kinds of solvents that are used to extract the THC from the plant, and then you get it in sort of a tincture or an extract, they found that these things contain naphtha, ethanol, petroleum ether, And the ones that were done at home, that you can extract it by yourself with using mineral oil or olive oil. These things still contain olive oil and mineral oil. The kinds of things that when you volatilize and you're inhaling it to get the effect, you're bringing along a lot of these other things that really are pretty dangerous. And they also found things like insecticides and pesticides, heavy metals. So the insecticides are, you know, they might say this is an organic product, we don't use insecticides. They were finding in some of their products that people still used pesticides or insecticides to grow the marijuana, despite it being advertised as not having in there. And the heavy metals are probably from what the marijuana oils are stored in, you know, containers that have lead and cadmium, a whole bunch of things that you really shouldn't be either ingesting by mouth or you shouldn't be inhaling. So it's just important to think about the lack of quality control can really have an impact on what you're getting or additional things you shouldn't be getting or potentially dangerous to be getting. Okay. So I want to talk about, I mentioned the endocannabinoid system, or the ECS. And I want to explain a little bit of that, because it's important to understand this before you can think about what is the effect of outside THC on normal development during pregnancy, and potentially after somebody is born and is breastfeeding. So the endocannabinoid system, just think of this. We as human beings, we all have this endocannabinoid system called the ECS, and it consists of two different things. We have our own cannabinoids that we produce ourselves, very similar in structure to THC and CBD. So we have two of them. One's called anandamide, and the other is called 2-AG, or 2-arachidonyl glycerol. These are biologically active molecules that we produce ourselves that serve a huge number of regulatory functions throughout the body. And we also have, as part of our system, we have our own receptors. We have our own endocannabinoid systems. There's CB1, cannabinoid receptor 1, and then there's cannabinoid receptor 2, CB2. Now the CB1 receptors are in the brain and the nervous system, and the CB2 receptors are in a whole host of immune cells as well as somatic cells. And the important thing to remember here is that this system has been identified as early as 5 weeks gestation. So here you are, you've got 5 weeks fetal development. This system is starting to be produced, starting to come online with both the receptors as well as these two cannabinoids that we have. And we keep this system throughout our entire life. So I'll talk about some of the things. Now, in the brain, where these receptors are located, they're located broadly throughout the brain, and they regulate a huge amount of things, like is brain development, so brain development prenatally, as well as the kinds of brain development that occurs in adolescents and young adults. So it can regulate memory and cognition. It is in the systems that are very closely tied to reward and motivation. It affects the system, the central systems related to appetite, immunologic function, reproduction, movement and coordination, and pain, analgesia. So you can see all throughout all of these different, this is the rewards area, this is the cerebellum for coordination, this, you know, and here we have the prefrontal cortex that's involved in judgment. The receptors are located all throughout the brain, so that this system regulates in part many of these different functions. And what, you know, how it functions is, I'll just give you a little idea of what's happening at the nerve cells. This is in the brain. How these things work is, so you've got a presynaptic cell here, a postsynaptic cell. So here are your endocannabinoids. They're in like these little cells that sort of sit next to the synapse. And what they do is the endocannabinoids are produced, they're dumped into the synapse, and they're taken up by these little receptors. Here are your CB receptors. They're taken up by these presynaptic cells, and then they affect the release of a whole bunch of different kinds of neurotransmitters, whether it's GABA, there are glutamate, serotonin, dopamine, all of these important receptors. So at the very level of the synapse is where the receptors sit, and the endocannabinoids, these are endogenous cannabinoids, work at the level of the brain cells, neural cells. Now, throughout the body, I mentioned we have our CB2 receptors that work on somatic cells. Now, so we are talking about lots of different systems. So you can see the cannabinoids can work in the cardiovascular system. Whoops. Whoa, got to go back here. Oh my goodness. I don't know how that went ahead. Whoa. Oh my goodness. I'm sorry, folks. We're already, somehow it just jumped ahead. My goodness, that was jumped ahead like 12 slides. Okay, so you can see here the cannabinoids affect the cardiovascular system, where you've got blood pressure, heart rate. It can affect the liver system with lipogenesis, can affect the GI tract with motility, the immune system. It can affect the interleukin, all of these immune and neutrophil components that comprise our immune system. And it can also affect pancreas with insulin sensitivity and secretion, as well as adipose tissue, where you've got lipid metabolism and free fatty acid oxidation. So this is where, when we talk about the CB2 receptors working in somatic cells and the immune system, not in the brain, you can see that this system has a incredibly wide variety of things that it can potentially affect. Now, I do have to say, we postulate these, we know it works this way. It's not clear exactly how it works and how much it affects it versus all the other things that we know that can affect the working, say, of our cardiovascular system or our pancreas or our immune system. But we know it's involved, so it just raises the issue of how much, and it also shows you how much we don't know and how much we really need to know to understand. Okay, so now I'm going to talk about, let's talk about the effects of prenatal exposure to marijuana. So we're going to talk about sort of the short and long-term effects seen in children, and I'll talk a little bit about the maternal effects, whether they're indirect maternal effects prior to the woman giving birth and prior to that baby being born. Okay, so if we talk about rates of use of marijuana during pregnancy, marijuana is the most widely used illicit substance in pregnancy. So, you know, compared to cocaine and heroin and methamphetamines and amphetamines, marijuana is really, it's really the most widely used. And you know, and you wonder why, because it's anecdotally, if you go online, you go on the social network, it is recommended as the safest thing for morning sickness. And it's also widely accepted as a harmless drug. And over time, it has become more and more accepted as being less harmful. So it used to be seen as more harmful maybe a couple of decades ago. Now, over time, people have seen it and have reported that they just don't perceive it as being as harmful as other things. So people are feeling that perhaps this is why we're seeing its accepted use during pregnancy as well as other times. I still want to point out, though, that tobacco and alcohol are still the most widely used substances. They're just not illicit, but they still are going to be more widely used than marijuana. And I've got some slides to show you in a moment. And we also know that we have documented there are increasing rates over time of use of marijuana in both pregnancy and breastfeeding. We've been documenting this with some of our national studies. I think you've all have documented it in some of the data that you have from the state of Maine. And if you started out being a user before pregnancy, up to 30 to 60% of users, marijuana users, continue to use throughout pregnancy. And I've got one study here by Wang, who reported in 2017 that the reasons that people continued to use during pregnancy, 39% said it was recreation. It was like, I used it before, I'm going to continue to use it. I don't see any problem with continuing to use it during pregnancy. 48% said they used it for their nausea and vomiting, so maybe, early morning sickness. And 60% said they use it because they're having pain throughout the pregnancy, and they find that really helped with the pain. And there have been studies, another study here that I quote that I've shown you by Young Wolf, that found that the users were more likely to be young, lower SES, and were more likely to use other substances along with the marijuana, like smoking cigarettes and also alcohol. And then they also were more likely to report emotional distress. And I think some of the data that you have from Maine shows that this is the case. Our younger people, whether they are between the ages of 18 to 24, 24 to 30, that population is more likely to be using the marijuana versus your people in the 30s to early 40s. They're more likely to use it if they're low SES and use other substances. So this is, I think the Maine data is consistent with what we're also seeing across the country as well. So if you ever want to know anything about substances, you go to the NSDOH, the NSDA, which is the National Survey of Drug Use and Health. And I pulled the most recent data from that national survey from 2020. And this just gives you an idea, what are the national trends in marijuana use during pregnancy versus non-pregnancy. And this survey, every year they survey about 50,000 people across the country, sort of a nationally representative sample, to get an idea of what is our population using, what percent of our population has use disorders, substance use disorders, and also what percent have access to care for their substance use disorders. So this is a wealth of information. And I've pulled a few slides from that survey, and you can see on the left-hand side that from 2017, I think 2017 was, not quite sure why it was such high compared to the other years. They think it might be the way they asked the question or the way the survey was analyzed. But you can see from 2018 to 2020, there's been increasing numbers of people who are pregnant between the ages of 15 and 44 reporting past month use of marijuana. And this is, of course, it's sort of almost half of what you see in a non-pregnant women. But you can also see that from 2017 to 2020, increasing numbers of our young women in the reproductive age are also reporting higher use of marijuana. It's almost 16%, 2020. Half of that are past month use who are pregnant. If you look at daily use, it's going to be less, but still, you had this high rate in 2017, but from 2018 to 2020, rates are increasing. Now it's almost 3% of pregnant women in this age group report daily use. Now, if you break it out by different ages, you will find it's going to be concentrated in your 18 to 24-year-olds and your 24-year-olds to 30-year-olds. So you can see here, now for some reason, I'm not sure why I understand this, but with the non-pregnant population of women, there are decreasing rates. So you've seen maybe 4.8% in 2017 has all the way down to 3.4%. So daily use with pregnant and non-pregnant are almost the same. And I did mention that, remember, tobacco and alcohol use are really higher rates than our marijuana use. So you can see here, past month use of tobacco, like all of your tobacco products, with the exception of e-cigarettes, past month rates of tobacco have really declined dramatically across all demographic groups and populations in the United States. So you can see that trend here, but we still have about 8.4% of pregnant women are using tobacco. Alcohol is pretty much about the same. You know, we've got almost 12% of women report past month use of alcohol. So again, keep in mind, even though marijuana is the most commonly used illicit substance, tobacco, alcohol still are much higher rates. And these are also things we have to worry about. Okay, so why do we need to be concerned about use of pregnancy and breastfeeding? And I'll spend the rest of the time talking about what is the data that we have to show why it is we need to be concerned, and where does that data come from? What do we know about outcomes? What do we know about, say, the pathophysiology of what's causing the kinds of things that we're seeing when an infant is exposed to marijuana during either pregnancy or continues to be exposed during breastfeeding? So the short answer is here. Why are we concerned? It's because of this endocannabinoid system that I talked about just earlier. This innate system that starts 5 weeks of gestation and continues pretty much throughout life. Okay, so let's talk about the endocannabinoid system during the fetal period. So I mentioned it can be detected as early as 5 weeks of gestation. Okay, so thinking about these CB receptors that are throughout in the adult brain, they're pretty much throughout all of those different sections that I showed you, everywhere from, from memory and motor coordination. Now, in the infant brain, okay, the locations, there are different areas of the brain that they're focused. It's not throughout. And the locations change throughout pregnancy, depending upon what area of the brain is undergoing the greatest growth and the greatest differentiation. So it's almost like, we're over here, we're growing our motor cells. Okay, this is where the endocannabinoid system sort of comes online, and you'll see more of your receptors focused in that area versus another area. So the thing is, I think the thing that we need to remember, though, is that these receptors and this system is focused in, we call the mesocortical limbic system. That's a fancy name for a system, okay, that has key roles in motivation, emotional regulation, rewards, sort of the kind of reward systems, and cognition. So these systems are where more of your CB receptors are located, starting as early as 5 weeks of gestation. So you can think about, what's happening in that brain during growth, during maturation, during development. This system is involved in some really key things, whether it's motivation, whether it's regulation, emotional regulation, or just sort of cognition. Over the course of someone's lifetime, we're talking about things that are happening early on that can have a huge effect as somebody goes through life. So these two, just how we're understanding how this endocannabinoid system works. These two are two endocannabinoids, that anandamide and that 2-AG. Those things in the brain, they're very clever. They are synthesized on demand. And so it's sort of like, well, we're coming online here. This is an important part of the brain. We need the system. They're for some reason, teleologically, it's happening. They are synthesized on demand. They bind to these receptors that I showed you, and they play a critical role. They play a critical role in regulating these neurotransmitters that really not only determine how the brain is functioning, but it also determines how the brain develops. So what we've learned, and we have a whole lot of research that comes from preclinical data. When it says preclinical, it means it means animals. So specifically rats and mice. But we also have an accumulating amount of data that shows what's happening in human brains, developing brains. So there are some sophisticated studies looking at developing brains. They use brains of fetuses that have either been miscarried or part of, say, an abortion. This is where the data is coming from. So it's not all just animals. We're talking about they've been able to look at human brains of fetuses to understand, and they've been able to find populations where the mother has primarily exposed that fetus to marijuana, and then been able to really understand what was going on at a different level of brain development. And so they're really understanding what's going on when a fetal brain is exposed to marijuana or the marijuana product. So they really understand now that the role of this system is in neuron proliferation, so creation, proliferation, growth, and migration of the neurons through key systems that are developing during brain development. So it has a unique role in microtubule function. Microtubules are the things that cause axonal growth, and the axons are the parts of the nerve cells that connect to each other. So they're at different parts of the brain. You're getting this system has a key function in growth, a production of neurons, growth of the neurons, migration of the neurons to form the different systems that are really key to give you an orderly, sort of an orderly fetal development of the fetal brain. So it's involved in, and it's felt to be very orderly. We have this system comes online, then we're now in this part of gestation. It's more important to be having motor development, different part, and that the ECS system is involved in sort of orchestrating and being involved in this very orderly development of the fetus brain, of the fetal brain. And some of the connections, like say the mesocortical limbic system, will project to the frontal cortex during a certain part of infant development and fetal development. That connection is key for decision making, higher order thinking. So just thinking of the kinds of important systems that this endocannabinoid system is involved in, I think we're just really beginning to understand, but it's looking like it has some key role in this orderly fetal development. Now, later in life, the CB receptors are more widely distributed throughout the brain, but it's more focused during fetal brain development. So how does THC affect this? So here we are, we've got this fetal brain that's going through this orderly development. Now we're going to introduce THC. So what's going on here, and why are we worried? Well, THC is very lipophilic. A pregnant mom, smokes marijuana, it crosses the placenta readily, gets right into the fetus. So, and there have been some studies to show what percent. So it's about 10% of the maternal level. So whatever that mom is smoking, that fetus is going to see about 10% of that maternal fetal level. So what does this THC do? Well, THC loves those CB1 receptors in the fetal brain, has a direct effect. It binds those receptors, and it binds so strongly it displaces the normal endogenous, that the anandamide and the 2-AG, and it has a direct effect by sort of disrupting the normal connection of the endogenous endocannabinoids to the CB receptors that are in the fetal brain. So the sense is it can hijack. What it does, it just sort of hits the system and it hijacks what is a very highly organized sequence pattern of normal neuronal development. So this is where people start to get concerned. It's like, well, what's the implication of this? Okay. So, and there's concern for development in those areas of the brain where the CB receptors are focused. They're mainly located. And people are starting to make the connection between what we're seeing behaviorally in children and adolescents who've been exposed to marijuana in prenatally. Now we're starting to see some of the neurodevelopmental effects, and people are saying maybe this is because this particular area of the brain is where the THC sort of hijacked normal development. Okay. So there's also, now there's new data coming out that there may be even indirect effects. So when we talk about epigenetic, and what epigenetic means is it doesn't change the chromosomes, it doesn't change the genes, but it changes permanently how genes are expressed. So what can an indirect effect of THC can affect how a newborn or a fetus's genes are going to be expressed. That is passed on to the next generation. So some people feel that this might explain later in life, that indirect epigenetic effect might explain what we're seeing in terms of increased vulnerability to substance use disorders in people who've been exposed to marijuana in fetal life. So not just direct effects. Now we're starting to wonder about what we're starting to see and be concerned about epigenetic effects, which are in systems that really involved in sort of dopamine, our reward pathways, memory, things like that. So if we think about that potential effect, okay, what are we seeing in terms of outcomes from kids who are exposed? So I'm going to talk about some maternal effects, but I'm also going to talk about developmentally, what are we seeing in these kids who are actually exposed? So maternal effects, just briefly, they've looked at women who have been using marijuana, what kind of effects? So there are some physiologic effects on the placenta. The carbon monoxide is increased when it's smoked 5 times more than tobacco. And that can cause some vasoconstriction of the placental vein. They've documented increased resistance of the uterine artery. It can affect placental circulation. So it's not entirely clear whether this is enough to give someone to have an effect, but these are things that have been documented with that felt to be related to the THC. Now, there was also a big study that looked a meta-analysis by Gunn that looked at the maternal effects, and they found that there was no increased risk of any maternal things like placental abruption, preeclampsia, maternal death, stillbirth, anything like that. So, I think that reassured people that they weren't seeing a direct effect on maternal outcomes. So people have really sort of focused more on, okay, if our maternal effects are okay, how are we doing with the infants themselves? Okay, so that same study also looked at early neonatal effects, and they looked at a whole host of things right at the time of birth. So they found the only thing that is consistent, the only effect that's consistently been seen is that they have lower birth weight. And studies have documented maybe it's 100 to 200 grams. And also, so the lower birth weight also translates, they're more likely to be under 2,500 grams. And I think your main data also supports that same thing, that you're going to see higher numbers are in that less than 2,500 grams than greater than 2,500 grams. So that seems to be the only early neonatal outcome. And there's really no good data to show that it increases preterm births, NICU admissions, or things like early neonatal behaviors like tremors, high-pitched cry. They looked at reactivity. And it's really not felt that there is a withdrawal syndrome like what you see with NOWs, with opioid withdrawal. There's really no clear consensus that babies who've been exposed will have a withdrawal syndrome. And there's no evidence for SGA babies or fetal anomalies, things like that. There is a more recent study than Dr. Gunn's meta-analysis came out of Norway in 2021 that showed that not only did they documented not only decreased weight, but a decreased birth length. So, you know, that's felt to be, it's more just size than anything else. So at the neonatal period. Now, there was one study that I did find just fairly recent that looked at co-exposure to marijuana and tobacco, because I think what we're seeing is many of the women who smoke marijuana, there's a higher co-substance use. So that population is more likely to be using tobacco or alcohol and other substances. So sometimes it's hard to sort of tease out what is really the effect of marijuana and what is really the effect of tobacco. So this is a study that said, you know, if they're smoking together, let's look to see whether there's a synergistic effect between tobacco and marijuana. And this study looked at newborn behavior the first postnatal month. And they compared they compared infants who had no exposure to any substances to those who are exposed to just tobacco, and then those who are exposed to both tobacco and marijuana. Excuse me. And they did this NICU network neurobehavioral scale, and they found that the babies that were exposed to tobacco and marijuana had a much lower ability to self-soothe themselves on the self-regulation scale of that scale. They had a less ability to attend to stimuli, so they were less attentive, and they needed more examiner soothing. So they needed more handling to sort of soothe them, and they also had a little bit more lethargy. So that exposure was double the impact of tobacco alone, even with a low rate of marijuana. So they concluded that adding marijuana, tobacco sort of was sort of a synergistic effect compared with tobacco alone. Interesting, they also found that the result was greater than for females, for daughters than sons. So I think, you know, this just raises the issue of what's going on when the two of them are used together. And I think this just sort of, you know, has us thinking about, rather than trying to pull out the independent effect of tobacco versus marijuana, maybe we need to think about what's the effect when multiple substances are used together. Okay, so I'm going to talk now about the long-term effects on children. And there are several studies that have provided most of the data. There's the Ottawa Prenatal Perspective Study that used low-risk white middle-class women, and they followed them from 1978. Now remember, that was when there were lower amounts of THC in the marijuana, but they followed them all the way through to age 22 years. And then there was a second study, the Maternal Health Practices and Child Development Study, that was a more diverse but higher risk, lower SES sample. And they followed them from prenatal all the way through to 16 years. There's another study called the Generation R study from the Netherlands that focused more on early growth. They used ultrasounds during fetal development, and they're still following those folks into older childhood. So the studies that we have about what are the longer term effects really come from these three big studies. So they measured the effect of prenatal use of alcohol, tobacco, and other drugs, including marijuana, on birth outcomes. And they measured later cognitive, developmental, social, and substance use behaviors all the way from early childhood all the way up into young adulthood. Now, I want to say that there's the caveat to these results is that no study's perfect. And these studies, the limitations were, they weren't able to measure use other than by self-report. So they relied on the women giving accurate report of what they were using and how much. So you don't know exactly the quantity or even the potency of the marijuana that was being used. Although we do know that back in the late 70s and early 80s, what you had available was a much lower amount of THC in the marijuana than what you can get now. And the other thing is that they had to do statistical controls for the use of tobacco and alcohol and other drugs because there were very few women who just were using marijuana and nothing else. So they had to do statistical analyses to control for the confounders. People feel that that's problematic. But the thing is that there's consistency of results across the studies. So with childhood, starting at 18 months to 3 years, they found these kids had impaired verbal, abstract, visual, and quantitative reasoning, problems with short-term memory and attention, and increased rates of impulsivity and hyperactivity. And I showed this slide just to give you an idea. You can see they followed from 18 months all the way up to the 17 to 22 years. And you can see over time, in your 3 to 6 years, you have deficits in verbal reasoning, visual reasoning, short-term memory. You're seeing increased rates of hyperactivity, attention deficits, impulsivity. That is still being seen at 9 to 10 years. And then by 14 to 16 years, you're still seeing things like deficits in visual motor coordination, academic achievement, some kinds of visual cognitive functioning. And then for that population that they watched, they followed right to 22 years, now they're reporting deficits in executive functioning. So maybe early on it was attention and impulsivity. Now it's more problems with executive functioning, still with working memory. And the other thing is now they're starting to see higher rates of substance use and earlier initiation of use of other substances. And then there are some studies that looked at brain changes. So these are some studies that then said, okay, what's going on with fMRI, or looking at PET scans, what's going on with anatomy. And they found that in our adolescents and young adults, there is some increased neural activity during inhibitory control tasks that relate more to what's impulse control. They've looked at, they've seen different functioning during visual spatial memory tasks, some disruption of the opioid and dopamine neurotransmitter systems. So this is sort of structural and more specific look at how the brain is talking to different parts of the brain rather than behavior. And now there's a concern that maybe some of these changes that they're seeing might explain why the prenatal causes more long-lasting changes in behavior. So people are starting to see what we're seeing behavior, what's connecting up that behavior, and what's happening in early fetal development. So people are starting to sort of put the pieces together. So I'm going to move on to breastfeeding and marijuana use. So we all know the benefits of breastfeeding, that it decreases mortality in the first 6 months of life. There are reduced rates over childhood of a number of things, whether it's diabetes, obesity, childhood cancer, respiratory illnesses. And there are also benefits for the breastfeeding mom. That woman has lower rates of breast cancer, lower rates of ovarian cancer, type 2 diabetes, hypertension. So the WHO recommends exclusive breastfeeding for the first 6 months of life. The AAP recommends same thing, but they really prefer that you breastfeed all the way up through 2 years if you can. So it's sort of been expected that but it's also been expected that mothers who use cannabis during pregnancy are likely to use it during breastfeeding. So this is where now we're starting to worry, what's going on if a mom or didn't use during pregnancy, now she's given birth, it's like, okay, now if I'm breastfeeding, it's okay to start up back using marijuana. So I think now people are starting to look to see what's going on with marijuana from a mom. What is she going to give to the baby? And what are the potential outcomes of that? So data is really limited. I have to tell you, there is so little that we know about this. We know much more about alcohol. We know that alcohol levels in breast milk parallel the alcohol levels in the mom. And there's a very common practice of not breastfeeding a few hours after you've ingested alcohol to figure time to clear the system so the baby's not getting it. But we really don't know much about marijuana. We don't know much about the mother's plasma level, what goes into the breast, and then what the baby gets and what the baby does once it gets THC from breast milk. And we know even less about outcomes. So the reliance is on case reports, single studies, very small studies. So the thing is, there's still a concern that a mom using in breast milk can potentially prolong the period of direct transfer of cannabinoids consumed by the mom, not just to the developing infant, but there's still brain development that continues. As we know, after an infant's born, there's huge amounts of brain development that happens. So there's concern that all this is doing is increasing the period when a baby may be during brain development may be being exposed to more amounts of THC that can potentially affect brain development. So what we do know, there are early studies that show that marijuana clearly crosses into breast milk, highly lipophilic. It goes from the placenta, from the mom to the placenta to the baby. It also goes from the mom into the breast milk. And there have been some studies to show that the milk sample one study showed that the milk sample was 8 times higher than the maternal plasma level. So if anything, it was concentrated. And then another case report, these are case reports, showed that there were detectable levels of THC and a metabolite of THC in a sample of breast milk from a mom using marijuana. So the conclusion of these limited case reports showed that THC can accumulate in breast milk, and the infant can absorb, and there's concern that the infant can absorb and metabolize the THC. So there have been some recent studies, and this one study here took a sample of breast milk from marijuana using moms, and is a research repository, California, called Mommy's Milk. And they analyzed them to see, these are women who report using marijuana. They provided samples to see, and then they measured what was in the mother's milk. And they found that 63% of the samples had detectable levels of THC up to 6 days after use. So unlike the mom who might say, I'll wait 2 hours before I have a drink and then I'm okay with the breast milk, they were finding that for some of these women, you could detect this up to 6 days after the last use of marijuana. So it was either staying in the mom longer, that she was producing it, or somewhere it was taking much longer for the mom to clear that amount of THC. They also detected a metabolite, the 11-OH-THC. They did not. They also detected cannabidiol, but there was no cannabinol. So the half-life on average was 27 hours. And the longest was up to 6 days. So they also found that the more a mother used each day, and if she used it by inhalation, as opposed to ingesting it with, say, a brownie with THC in it, there were higher concentrations. And they did not have infant levels, but they estimated that the baby was getting about 1,000 times lower than the adult plasma level. Excuse me. That is just an estimation, because the next study I'll show you talks about a little bit different. So they concluded that the infant that's nursing can accumulate cannabinoids because of the slow elimination from body fat stores and daily exposure of the mom. And then no one knows how the baby's going to metabolize this either. So the baby could be accumulating it, just prolong the extent that the baby's developing brain is exposed. And then there's a second study here that looked whether or not THC and cannabinoid accumulated in breast milk. So they had 20 breastfeeding moms, and they did maternal plasma and breast milk simultaneously. So they looked to see, because this previous study, they estimated what the concentration was. So they found, the same time they had a level of the breast milk, a level of the plasma. And they found for THC, there was about, plasma had 3.7 nanograms, breast milk had 27. So there was actually an increased concentration in the breast milk from what the mom's plasma was. Cannabidiol it concentrated less. It was only a ratio of 2.6. So they concluded that both THC and cannabidiol can accumulate in breast milk at levels that are higher than seen in plasma. Now, what the baby gets, that was sort of the next step that they didn't take it. So those are things that we really need to know. Excuse me. So in terms of outcomes, there is even much less information about the effect on babies who've been breastfed by THC using moms or marijuana using moms. What might be the developmental effect? And there are just a couple of studies, very, very small samples. One reported decreases in motor development in those exposed to breast milk at 12 months. And those was only with daily or nearly daily consumption. And then there was another study that showed there was no difference in mental or physical development in 27 one-year-olds compared to 35. Those were intermittent use. So I think we just really don't know. So I'm going to finish up here with just telling you that the ACOG recommendations are that we do verbal screening of all women throughout entire pregnancy and recommend abstinence for substances. And they strongly recommend abstaining from marijuana during breastfeeding, but they do not consider a contraindication. Now, the AAP says to screen women considering pregnancy, or if you have a prenatal visit or are pregnant or considering pregnant, and counsel that the safety is not known, but we have reason to be concerned. So rather than, just say, look, we have reason to be concerned, so let's be prudent. And the better thing to do, the safer thing to do is to stop using during pregnancy. But in terms of breastfeeding, we know there are so many more benefits to breastfeeding that it's not considered a contraindication, but what they recommend is that you recommend to the mom, if you are going to breastfeed, that's great. If you can cut back on your marijuana use or stop, that's even better, because we just don't know. But we just don't know. And I think, again, we have to be careful about screening. You have to know the laws in your state. I'm referring to CAPTA, so that you can counsel that woman about the potential consequences of reporting. And I know you're all familiar with CAPTA, that basically the interpretation is state specific, and that a physician may refer to the Department of Health when a child is exposed to alcohol or a controlled substance. And it can create an ethical dilemma. And it may be why many of our OBGYNs are reluctant to do some screening, because of the concern about what might happen if it's in the record, and that goes to that record stays until the mom's delivered. Now, I want to raise one question for you all, which is what are the effects to think about the effect of marijuana use on early parenting, beyond modeling? Because if you consider the acute effects of intoxication, what we're now starting to see in Pennsylvania is that we're starting to see reports that are linking early infant deaths from SIDS, co-sleeping, and poor back-to-sleep practices with use of substances by parents and detectable levels of THC in moms. And that is now becoming the most widely detected substance in a mom who comes in with a baby that has had an early, within the first year, death. So I think we have to be thinking about, not just modeling of substance use by our parent, but what is the effect of marijuana use on early parenting? When you think about the acute effects, and I've listed your acute effects here, they're intoxication, relaxation, distortion of time, delayed motor coordination, hallucinations, anxiety, memory impairment. So, if we think about what a new parent, how alert and a new parent needs to be, I think we have to think about what is the potential effect of an intoxicated parent on how that parent is able to provide the best parenting or the best supervision for that infant. And I'll just leave that out there as a question for you all to think about. So why are we seeing increased acceptance? If it's legal, it must be safe. For teens, they say if it's okay for adults, it's got to be okay for us. And there are no good public health measures that make marijuana not cool to use, unlike what we have for tobacco and cigarettes. And then there's a study that I found that OBGYN people admitted not being familiar to the risks of marijuana during pregnancy, which is why they didn't really push the abstinence of marijuana versus alcohol and other illicit substances. And they themselves perceived marijuana as less dangerous than other illicit drugs. And they were more focused on the risks of child protective services if testing is positive as delivery. So they needed more education about what are the potential effects of marijuana use during pregnancy, either alone or with other substances. And the biggest problem is why we're seeing such increased acceptance is that more than 65% of the American population supports the legalization of marijuana. And we're seeing that as things go on. So I'm just going to stop there because I wanted to give some time to see if there were just a few questions that came up. I know you all will have access to the slides, so you'll be able to go back to the slides. But I want to thank you all for giving me this time to talk about this, what I see as such an important topic. And should I stop sharing there, Rob?
I think you can stop sharing. Yep. There are a couple of questions in the chat. And some are also just a few comments. So one is making the point about cannabis policy in Maine, just for those that may not be following the chat. In looking at contaminants, there is a testing requirement for our adult use market related to cannabis, but there are no testing requirements for our medical cannabis. So just for people to be aware of that and recognize that. Mm-hmm. There was also a question specific to terminology. Is it not just smoking marijuana? I assume we're really talking about any form of consumption. Is that correct?
Correct.
I think it's important to clarify that this could be the non-smokable forms.
Yeah, and some of the studies have shown that say for a mom, the rates that she will pass on to the baby are sometimes higher if it's been through inhalation. But THC is THC. the other point I didn't make is that when you inhale THC and you breathe it out, only 50% of it is metabolized. 50% goes back out into the environment. And so passive smoking, I didn't mention passive smoking, but with inhalation and smoking, there's potential exposure through that you don't get when it's ingested, say with food that you've added, say an extract you've added to a food. Yeah.
And we do have another question. Are there numbers for how often people are using cannabis in their daily lives and then just continue use when they are pregnant because they think it is either not harmful or helpful for the baby? I hear a lot about this in local personal settings. Curious if there's any data.
Well, it varies. That was a 38 to 60% data. And I think actually there is Maine data, that Maine keeps from excellent data. So I think there is Maine data, but across the nation, a user, so that would be that, excuse me, that would be that 14% of a non-pregnant woman, up between 30 to 60% of those users will continue to use. Now, it tends to fall. So there's higher use in first trimester that drops to a little bit less in second and a little bit less in third trimester. But it's still a significant number that start out using will continue to use, and then they'll continue to use after breastfeeding. Yeah. Great.
And then another question or curiosity is what others think about the mandated notification with only used loosely marijuana. So that notion of that mandated report, thoughts on that?
Well, I think that's where each state has its, where with the state, there's a requirement to report, but it's almost sort of the reporting, is it reporting as opposed to reporting that generates something that becomes a child protective, that then we start to worry, have to do a plan of safe care, when it could be that, a mom was using and then she starts her pregnancy and she's not using at all. So that, I think this is where physician discretion and saying, this is a mom that, is providing all the kinds of things, there isn't a prior history of child protective involvement. They cut back, they're doing everything that they need to do, and we're not worried, as opposed to somebody that you've got all the red flags that are raised. I think this is where, if you just have a across the board interpretation, everybody who's positive has to get a child protective referral. I think that there have been some states that have done that. And that, when it gets into nobody wants to report, nobody wants to ask because nobody wants to hear the results. So, hopefully there's some sort of reasonable interpretation of the difference between a child who's really at risk versus one that is not.
I think we have time for one last question. Curious if you have any thoughts related to pregnant women, newly delivered women that may be experiencing postpartum, that have a history of an anxiety or depression, who are also screening positive for cannabis use, and any correlation with postpartum depression.
Well, there's probably a stronger relation between anxiety. I don't know of any study that's linked postpartum depression, but the thing is, about 18 to 20% of pregnant women who are users of marijuana will have a diagnosable cannabis use disorder, and that's the DSM-5 diagnosed. Now, many women or many people will use substances to self-medicate. So it's entirely possible that that woman who had maybe some depression in pregnancy finds that the effect of marijuana helps with the helps with the depression, rather than using therapy or Prozac or something. And it could be that it's the postpartum, the use during pregnancy and in postpartum could have been an indication that that woman had earlier depression, was medicating herself because the marijuana made her feel better. And that could be why you might be seeing more of it, because it helped during pregnancy to sort of help with the depression she was feeling. Yes.
Well, thank you very much. I know you can't see the chat. There's been lots of compliments and thank yous, really expressing how important this topic is. And I just want to encourage people to stay logged on before you leave for break, where we are going to be listening to one more recovery story. So thank you again, Dr. Ryan.
Thank you again, and I really appreciate being asked to share this important information with you all. Okay, you take care.
I already think the worst about myself. I don't need to hear it from somebody else, Like, no matter what you're saying, I guarantee I'm saying it 10 times worse than you. My last trimester, I did end up using, which emotionally destroyed me, but I couldn't be honest with anybody. I was in so much pain. Like, that was my excuse. That's how I was able to accept what I did, because my doctors weren't helping me. First of all, I know my chart says that I'm an addict. I'm red flagged. First of all, like, there's the judgment as soon as I walk in. You don't know my story. You don't know anything about me. You just automatically made up your mind before I even came into your office. And that is very frustrating. I went through a lot of my life not getting proper medical care because I was written off as, oh, she's just looking for drugs. Oh, it doesn't matter. She's not telling the truth. And if one provider thinks I'm not being honest, then you need to be talking to my other providers. They're going to be honest if I'm not being honest, And I wish more providers would be like that. Be open-minded. I understand about compassion fatigue, but we do recover. We do recover, and we are human. I am somebody's daughter. I'm somebody's sister. I'm somebody's aunt. I'm a mother. So it's just about compassion and more know your patients. My name is Angela Crabtree, and I have been in recovery for a little over 2.5 years. Recovery has been the best thing in my life. I am going to be starting school in the fall. I have been more passionate about things in my life that I thought that I would never be able to do again. And you don't have to give up on all of your dreams, even with a background. I have a felony background, but that's okay. I can still do some of the stuff that I thought that I wasn't going to be able to. I do a lot of family stuff, and playing with my children, going to the park, I'm more family oriented today than I've ever been. It's amazing and it's beautiful, and even though I don't know what I'm doing half of the time, I wouldn't change it for the world. It's been difficult as a single mom, but I'm very proud of my children. I don't even have any words to really describe what my life is going to be. It's just, I'm full of joy right now. And that's what my life looks like today.